Hello, everyone. Thank you so much for listening in today. And I also wanted to say a special thank you to everybody at Dr. Brown's and Handi-Craft Company for putting this together. So I just want to make a quick disclaimer before we start that I did not come up with pacing. I pretty much, I think I owe that to Catherine Shaker and Marjorie Mayer Palmer. Those were the first two presenters who I heard speaking about pacing. So I don't want you to think that this was my baby, but I do wanted to spend the time with you guys to kind of go over the whys and hows. As I go through and meet other people and speak to other hospital groups about pacing and general feeding preemie babies in general, we are seeing that there's a lot of discrepancies and a lot of questions coming up about pacing. So when I was invited to give this lecture or a lecture, I thought this was going to be a great topic to touch base with everybody on. So quick financial non-disclosure. I have nothing to disclose to you guys. I just enjoy talking and educating. All right, so our objectives today, we're going to identify if an infant has an uncoordinated feeding pattern that might require the need for pacing. We're going to go through some of the evidence, and we're going to talk about the types of variations that we often see people pace their babies. And we're going to understand why certain infants might need one variation versus the other, and just the general why in general. Why is this so good for our kids? So the pacing technique. This is the use of an imposed break during an infant's feeding to facilitate improved feedings, right? But specifically, we're going to be having improvements in burst pause rhythm, breathing regulation, bolus control. Again, I got this right from Shaker in 2013, Catherine Shaker. But what it results in is really this improved endurance. When you think about endurance, I want you to think about the feeding time and then the fatigue that we often see at the end of those feedings we could maybe prevent with these pacing techniques. And safety, when you think of safety, I want you to think of aspiration risks. But I'm also going to add to this slide, we want to encourage positive, stress-free feeding skill development. This is going to improve our long-term outcomes because there are negative consequences to stress in the unit for these babies. But before we get into the nitty-gritty for the pacing technique, we are going to do a quick review of the development of suck, swallow, and breathe. So what we know is that it does follow a very predictable pattern of timed neurodevelopment, and we often look at our fetal studies to understand what our preterm babies are doing. So if we think about the normal development of this pattern, we see that babies start to suck and swallow as early as 12 or 13 weeks gestational age in the womb, sucking and swallowing on that amniotic fluid, their fingers, their umbilical cord, whatever they can grab. Around 32 to 33 weeks, we see a lot more rhythmicity with that, really kind of priming the stage for future feedings. But it's not until 34 weeks gestational age do we see a true didactic sequence of suck, swallow, suck, swallow, suck, swallow. And this is usually a cornerstone age why some babies, some units start feeding at 34 weeks gestational age. And this is great. This is a great time to start. They're usually having more periods of awake and alertness. They have this didactic sequence of suck and swallow. However, to be an efficient feeder, to really be a good eater at this age or any age, you need the development of suck, swallow, and breathe. Unfortunately, that doesn't come in until closer to 40 weeks gestational age. All right. So what this means is that there is a solid 6 weeks for some of these babies that we're expecting them to feed and to eat in a way that neurologically they may not be fully prepared to do. Okay. And what we often see is closer to this 40-week mark is a true suck, swallow, breathe pattern. We call that the mature sucking pattern. Suck, swallow, breathe, suck, swallow, breathe, suck, swallow, breathe. Prior to that time, though, around 34 weeks and on, or for full-term babies who may have some medical complications or issues, we often see an immature sucking pattern. So a little overview of the mature and immature sucking patterns. Again, it's usually a 1:1:1 suck, swallow, breathe ratio, but it could be 2:1:1 or 3:1:1, where these babies might suck a couple more times before initiating their swallow. That's normal, but it's very rhythmical, very predictable. The baby won't have a lot of stress cues. And then thinking about this mature sucking pattern, when you have this suck, swallow, and breathe, suck, swallow, and breathe at a rate of 1 per second, you have to open your airway to breathe, and then you have to contract all of the muscles within your airway to close it off for a safe swallow. So there's a lot of very fine motor movements needed for this mature sucking pattern. Open the airway, close the airway, open the airway, close the airway, right? So because of that difficulty with that coordination, that sensory motor process for safe swallowing, we often want these kids to stay at a more immature sucking pattern. And they separate that sucking and swallowing from the breathing pause. And it sounds like this. Suck, swallow, suck, swallow, suck, swallow, suck, swallow, pause to breathe, 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 breathe. And then they kind of go back. Suck, swallow, suck, swallow, suck, swallow, suck, swallow. And then they pause to breathe, breathe, breathe. Instead of being this mature pattern of opening and closing the airways, they're keeping the airway closed and all of those muscles really nicely contracted for their sucking and swallowing bursts to make sure that the airway is protected. And then once they have that final swallow of the burst, they relax their muscles, their vocal folds, their larynx from being elevated, and their velum from closing off the nasal passageway so that they could breathe very, very easily. And once they felt like they've oxygenated adequately, they close everything up again and go back to their sucking and swallowing bursts. But both of these sucking patterns, they're very rhythmical, they're very predictable, and they are not accompanied by stress cues. So we consider both of these sucking patterns to be self-regulated. These babies don't need us to pace them. They've got it. They can suck and swallow and breathe and do not run into problems immediately. All right. So again, we do not need to pace these kids. These kids, they've got it. All right. I'm going to show you a quick video now of a little girl who at the beginning of her feeding was showing a mature sucking pattern, and then towards the end of her feeding was showing more of an immature sucking pattern. A few things I want you to focus on when I play this video. For the mature sucking pattern, focus on her nares. You're going to see at a rate of 1 per second, they flare, indicating that she's breathing once per second. And also pay attention to her jaw moving rhythmically up and down. And that's going to be an indicator that she's sucking and swallowing at a rate of 1 per second. And then when we transition to the immature sucking pattern, I want you to focus on those bursts, short bursts of sucking and swallowing, and then short bursts of breathing. Nice and rhythmical, no stress. Everything happening about once per second. Here, she pauses to breathe, and then on her own goes right back into it for her sucking burst. And she pauses to breathe and goes right back in. Okay, well, she was about to. Very rhythmical, very coordinated, no reason for distress there. But in truth, how often do we see babies show very well coordinated sucking and breathing patterns? It is pretty infrequent. Most often we see poor suck, swallow, breathe coordination, or what we call a disorganized sucking pattern. And this is partly due to neural immaturity, partly due to poor physiologic stability, and can be also partly due to the environment of the feeder, what we're doing to try to help them or not helping them. All right. And the disorganized sucking pattern, it is not rhythmical. It is not predictable. It is accompanied by stress cues, and it's everywhere. It's suck, suck, breathe, breathe, swallow, swallow, suck, suck, breathe, breathe, swallow. There is no knowing what this child is going to do next. All right. And when we think about the disorganized sucking patterns, there's 3 main consequences or patterns that we might see. One of them is this extended airway closures. And I love these kids because, you know, I'm working with the parents and it's the first feeding and I go to put that bottle in the baby's mouth and the parents are ecstatic because the baby is sucking and swallowing away. They're going for it. Suck, swallow, 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 suck, swallow. And finally, I have to look at the parents and totally rain on their parade and be like, Mom, baby's not breathing. Baby is just sucking and swallowing and will eventually suck and swallow themselves into a DSAT. So these extended airway closures we see mostly because of their neurology, right? So just thinking back to this natural pathway for them, we see that, you know, between 34 and 40 weeks gestational age, they don't have those good neural pathways for breathing. But the neural pathways for sucking and swallowing have been around a long time for them. So they have had a lot of practice sucking and swallowing. Again, those neural pathways to the brainstem are very well established. but the neural pathways for breathing are not. All right. So we often find is if there's a nipple in that baby's mouth, or if there's liquid in the baby's throat, both the suck and the swallow reflexes will override the breathing reflex, all right, which is obviously pretty dangerous for them. And it's due again to this neural immaturity. So that's one consequence. The second consequence we see are these fluid threats to the airway. And that's pretty clear to see why. Going over that mature and immature sucking pattern, we know that there's a lot of fine, precisely moved contraction of the airway safety musculature to close the airway and then open the airway. But if this kid is disorganized and it sucks, suck, breathe, breathe, swallow, swallow, suck, breathe, and it's all over the place, it's very easy to understand how liquid might in fact penetrate the laryngeal vestibule or the trachea in either penetration or aspiration. And these are things we definitely want to avoid for these children to prevent long-term respiratory compromise. And then the third is a reduced rate and depth of breathing. These kids, we know that they're probably going along, they're feeding, maybe they look okay, but because that suck and that swallow reflex might override the breathing, sometimes they stop to breathe, but they don't take enough breath, or they don't take a deep enough breath. So these are the kids that may end up being very huffy and puffy with their feeds because they're not taking in enough of what they need. I also see this sometimes in kids that are trying so hard to have a mature sucking pattern. So instead of going suck, swallow, breathe, suck, swallow, breathe, suck, swallow, breathe, they take these short little staccatos. They're like short, suck, swallow, breathe, suck, swallow, breathe, suck, swallow, breathe. And there's just over time not enough depth of that to support the task of feeding. All right, so I'm going to show you a video. Oh, sorry. These kids are unable to self-regulate. They cannot take good respirations. They can't stop their sucking and swallowing bursts for those respirations. They're at risk for aspiration, and so they need us to regulate for them. All right, I'm going to show you a quick video rather, of a little girl who has an immature sucking pattern. And things I want you to focus on for this video are the lack of bursts, the lack of clarity. Well, what is she going to do next? Is she going to suck next? Is she going to breathe next? And I really want you to focus on her eyes. All right. So you see a bunch of flinching movements, some eye stress, taking a look at her jaw. She'll take sometimes some very small little sucks. And taking a look at her nares, her breathing pattern isn't very rhythmical. At some point, she's going to sputter a little bit on her liquid, indicating to us that she has some fluid mismanagement. Oh, there she goes. And then look at that stress cue on her face. All right, so an immature sucking pattern, very arrhythmical, unpredictable, accompanied by stress cues. All right, so thinking about this disorganized sucking pattern, sometimes if we're not paying attention to what our children are doing when we're feeding them, we find that they just go. They take it. They don't know what's right or wrong, and they're just kind of going with it. So this isn't preference for us at all. What we would much rather see is they go through their feeding in a much more controlled jog, right? So we want to make sure that everything we do can avoid this sprinting and this fatigue and keep this child at a much more steady pace. And this is really where the pacing technique comes in. The use of imposed pauses to help regulate that suck, swallow, and breathe regulation. So we're going to talk now about how to pace. And there are really 4 main ways to pace. As a disclaimer, I've done all 4 of these in my career at some time. And after we go through these techniques, I will share with you what my unit and I prefer to do now. So one of them is tilting the baby along with the bottle still stable in the baby's mouth. One of them is breaking the seal, the intraoral seal of the nipple when the baby needs to be paced. Tilting the bottle, we call these also dry swallows when the baby needs to be paced, as well as removing the bottle from the baby's mouth. All right, so we're going to show you some pictures of what all of these look like. So when we're tilting the baby, we feed the baby, and then when the baby needs to be paced, we're going to tilt that baby forward while keeping that nipple very steady in the baby's mouth as to not to stimulate the suck reflex. So that is one option. Second option is breaking the seal, the intraoral seal in the infant's mouth. So again, as you feed the baby, when the baby needs to be paced, you kind of pull and push the nipple into the side of the buccal pads and the gum ridge, as you can see in this picture. The third way is by tilting the whole bottle. So again, we feed the baby. When the baby needs to be paced, we hold the baby stable, just pull the nipple and the bottle down. And then we have, by removing the bottle, feeding the baby, and when the baby needs to be paced, you pull the nipple out of the baby's mouth and leave it on their lower lip. All right, I have a quick graph here of some of the pros and cons to each of those. Tilting the baby was something that when I first started pacing in the unit, well, actually 10 years ago, and then in the unit 8 years ago, I learned during a seminar. And I would say about 6 months after that seminar, it was in 2012, I was at a conference and I got to hear the great John Chappell, or Chappell, I'm not quite sure how to say his last name. And unfortunately, he passed in 2016, which was devastating because he was a phenomenal speaker and passionate about neonatal. He's actually a PT, so he's a neonatal PT. But anyway, I heard this great talk, and he told us that he reported on research that when you move the baby's plane, their cranium has poor blood flow redistribution, so it actually may make these babies dizzy. So again, I was like new to my unit. I went to this great conference, and at the time I was pacing these babies by tilting them, and then I saw his lecture and I panicked. I was like, oh my goodness, we're making these babies dizzy. So I stopped doing that. Other reasons why I'm not crazy about the tilting the whole baby technique is just because you tilt the baby, it takes them a couple of sucks to realize that there's no milk there. And in that time, they may actually suck and swallow some air, which could increase their reflux. And so when that happens, you still may need to remove the nipple. So a little bit of a confusion could happen with that. But a pro is it doesn't stimulate their suck reflex because you're holding that bottle very stable in the baby's mouth. But again, at this point, I do not longer do that one for the fear of making these babies dizzy. The second one is breaking the seal, and it is pro because it does stop the sucking right away. You're unbreaking the seal, so they're not going to continue sucking for too long after that. However, I worry about creating some abnormal sensory input to the gums and the buccal pads because it isn't a typical, kind of using breastfeeding as our gold standard. At no point would that breast ever kind of go into those pads or into the sides of their cheeks. So breaking the seal is also something I'm not a big fan of in my unit. And then for probably the longest period of time, we were tilting the bottle. And I know a lot of units still do this, and it is reinforced by a lot of our infant-driven paradigms. And it does have a lot more fluidity in the movement. You see the baby needs to be paced and you pull that nipple down. My biggest concern with this, again, is that while you're pulling that nipple down, it does stimulate the suck reflex, which is going to make those kids actually suck a little bit more, thereby increasing the risk of them swallowing air and having reflux, because that air can get trapped in their stomach and distend their stomach walls, which will cause a more rapid recoil and cause reflux. So with that, we often do need to then remove the nipple afterwards. And we had done this for probably the longest stint of time. And about 3 years ago, we decided to kind of move away from this approach. The main reason why was because, you're working with these families and they're already anxious about feeding their babies. And you go through this time educating them about why we want to pace. We want to pace because we want to stop them from sucking and swallowing to then breathe. But it's kind of this like, well, if A doesn't work, try B. And if B doesn't work, try C. So oftentimes these parents would be trying to feed the baby and they tilt the nipple and the baby's still sucking and showing stress. And then they look at you and they're like, oh my God, well, what do I do? I'm like, oh, well, now you have to pull it out. So after kind of saying that so many times in a row, and for some babies needing it almost all of the time, we found that it was almost more fluid and an easier teaching process to just remove the nipple from the get-go. So that is what we're doing now. And it is pretty proficient at stopping the sucking because the nipple is out of their mouth. But there is less fluidity of movement, of course, when compared to tilting the bottle and leaving that nipple in their mouth. So we're going to kind of talk through some of these, but whatever you decide to do, consistency is really important. I'm going to show you a quick video now of what all of these kind of pacing techniques look like in action. I know I showed you pictures, but now you're going to get action. Okay, so this is tilting the baby. There you go. Even though it's a slight movement, especially when you're in an elevated side lying position, I still am concerned about that dizziness for them. All right, so now by breaking the seal, this baby's being paced to 8 sucks per burst, and then you just break the seal and kind of leave it there in their mouth by their gums. So you can see how abnormal that looks for that baby. So again, I do worry about those altered sensory inputs to the buccal pads and the gum ridge. But what's nice is that once the infant is ready, they show you a sign and then you can go back in. It was being paced to 8. Now we have tilting the bottle. There you go, you just pull it down. So there's a lot more fluidity in that movement, but look how that baby keeps sucking. Finally, the baby stops. And she's gonna give us a cue when she's ready for it. There it is, and you go right back in. So much more fluid. And there she goes. She actually self-regulated all on her own. Went back into her own sucking burst. A little disorganization, but she's not in much distress. And then I believe in this particular instance, I heard a squeak, so that's why I pulled it down. But you see how long it takes her to stop to finally stop? So that's where the confusion lies. So I don't think any of these are necessarily bad versus being good. They're just a little bit of a different perspective. She's going to give us a cue when she's ready to go back. There she goes, and you just retilt right back in. And now we have by removing the bottle, and this is to stress cue. So there she goes on her sucking burst. And I'm just going to let her go until I see a sign of stress. And what I do is I keep those fingers on her face, and I leverage off her face when she needs to be paced. There was my stress. So I bring it out, and I leave it resting on the lower lips. And again, I'm going to wait for her readiness to when I can go back in. There she goes. She opens up for me, and I go right back in. Couple of nice sucking bursts, and I'm going to wait for that next sign of stress. She's trying to regulate on her own. A little disorganized. A little fluid mismanagement. And that's the stress that I decide enough is enough. Give you a little break. All right, so again, I was paying really close attention to her sucking and swallowing bursts to dictate when she may have needed a pause. All right, so those are our 4 types of pacing techniques. And as I mentioned before and cannot emphasize enough, consistency matters for both these infants and for the parents. All right, so when you are talking about pacing, I want you to look at your colleagues and I want someone to spearhead this. There really needs to be unit-wide consensus about which technique you want to use. And the best example I can give you for this is imagine being a mom or a dad and having to first leave your baby in the unit and go home, and the lack of feeling like a parent that can cause you. But when you finally do get back into the unit to see your baby and you have to help them with these tasks, you want to feel like a parent. You want to feel like a good parent, and you want to feel like a proficient parent. So imagine mom or dad comes in on Monday and has nurse A. And nurse A is like, okay, so we're going to do the feeding with your baby, and we're going to pace to stress cues, because really generally every baby should be paced. When you see stress, you pull the bottle out or you pace them. And so let's say nurse A on Monday says, we're going to pace by breaking the seal in the infant's mouth. So nurse is spending all this time teaching mom and dad are practicing. They do this for the whole day. They go home at night and say, okay, I did this. I was helping my baby. Awesome job. Show up the next day on Tuesday, and now they have nurse B. And nurse B is like, oh, no, don't pace that way. Pace by just tilting the bottle down out of the baby's mouth. So now the parents get to lack that feeling of feeling proficient. they're going to say, oh, but I just practiced all of this yesterday. Okay, well, let's learn it now. And then they go through this learning process. They feel good by the end of the day. They go home. The next morning they show up, and now nurse C rather is saying, oh, no, we're going to pace by pulling the nipple out of their mouth. So consistency matters. It really matters for these parents. We want to empower them. We want them to feel really proficient when they feed them. Imagine the difference of their psychology when they get taught by nurse A on Monday, and then they come in on Tuesday with nurse B, and they're feeding the baby, and nurse B is like, wow, mom and dad, you're doing such a great job pacing her. I love how you're doing that. Imagine what a difference that's going to make for a parent. So again, unit-wide consensus regarding which one you're going to use. All right, really important. At this point, again, I'm okay with probably the last two options, either tilting the bottle out or removing the nipple from the mouth entirely. And I kind of gave you my reasons why. So again, just to support a little bit more of my decision, and there are a couple of tips that I often say to parents. I do like to anchor a few fingers on that baby's face, and that provides just a little bit of a stability port, which will help with mobility, which is great. But when I go to remove that nipple, instead of just like popping, like suction cupping that nipple out of their mouth, when I have that anchorage, I can leverage off their face a little bit and make it a little bit more of a fluid movement. I also tend to twist and pull at the same time, again, so it's a little bit more of a gentle unlatching. And I always leave that nipple resting right on that lower lip. I'm not holding the bottle, a foot away from them. I want them to feel the stimulus there, because when you do that, it does aid in the fluidity of everything. You leave it resting on their lower lip. They show you a sign that they are ready for it, and then you open up and you can go right back in. There's no need to tap or rub their lips to re-stimulate it. They know it's there, all right? During that rest pause, we want to facilitate a good rest. So how easy would you be resting if someone was tapping something on your face, right? So we want to just keep it right there for them. I would say if they're not responding to it longer than maybe like 15, 20 seconds, then I would try to re-stimulate it. But I think anything under 15 seconds is a nice rest pause for some of these kiddos. All right. So now we're going to talk about when to pace. And I did mention by stress cues. This is very restrictive, the least restrictive, and it should be done for all infants every feeding. All right. Now, this is common sense, right? You're feeding a kid and they start to sputter and cough, you pace them, right? But we're really going to be paying attention to these minute details of stress cues. We're going to go through them. But first, should know this is going to be determined by the infant, and those needs, they're going to change minute to minute. So maybe they didn't need to be paced so much at that 8 a.m. feeding, but now at the 11 a.m. feeding, they need a lot more help. So we're really just going to be in tune to what these infants need. And if you're in doubt, if you're not really sure, do they need a break? Do they not need a break? Take it out or pull it or tilt it, pace them, because breathing can't hurt for sure. So when we're thinking about this disorganized sucking pattern, and we have these three main consequences of that disorganized pattern, while this infant is going through these patterns, they are going to be having stress. And that stress will allow them to have these behavioral stress cues. So Dr. Suzanne Thoyer, who's a really great neonatal nurse who takes a big liking into neonatal feeding, she's come up with some of these stress cues that could happen during these three types of disorganized feeding patterns. So when you have an infant with an extended airway closures, sometimes they pull away or have finger splays, extending their arms, pushing the nipple out of their mouth, eyebrow raises, furrowed gaze, flailing around, very, very visible signs. When we have infants with fluid threats to the airway, infants with aspiration risks, we often see drooling or what we call anterior spillage. This is a smart baby who does this because they know, hey, I can't swallow this whole bolus. This is unsafe for me. So they spit half of it out. They have sometimes hard swallows, wet breaths, sputtering, yelping, gulping, coughing, nasal congestion, squeaking. It's not on there, but sometimes these kids will swallow and squeak at the same time, all right? And then finally, our reduced rate and depth of breathing. These kids will have increased work of breathing. These are our huffer and our puffers, right? They feel like they just cannot catch their breath. Sometimes they bob their head back, have stridor, grunting, color change, and nasal flaring, right? So here's a picture of a little boy who's having some stress. So if you were in front of me, I'd ask you all, well, what do you see? How do you know this kid is stressed? So we have a finger splay, we have a furrowed brow, we have a general feeling of concern. So this is the thing that always gets me, is I find that people who work with babies, nurses, nurse practitioners, neonatologists, therapists, we're some of the most compassionate people I've ever come across. And if I were to walk into any of your units with this face on, half of you would put down what you're doing and come up to me and be like, oh my God, are you okay? What's going on? But when we see this face sometimes in our babies, we chalk it up to immaturity or instability, and we sometimes don't pay enough attention or enough focus to that. So this is a child who is definitely not having a great time during their feedings. In addition to stress cues during a feeding, Catherine Shaker points out there's also cues for physiologic instability. These are those kids that sometimes start off the feeding wide awake and ready to go, and like 5 minutes into the feeding, they're asleep. That is not a great sign of physiologic stability. Sometimes we start with the feeding and this baby has really good flexor tone, right? They have nice hands to the mouth and good postural supports. And then as the feeding goes and they get more tired and more tired, they become more flaccid and flaccid and flaccid. So again, a good sign of physiologic instability. We have cardiorespiratory behaviors, change in color, respiratory fatigue, tachypneas, unstable saturations, Brady's or apneas. All of these things, again, not great to see during a feeding. And then Catherine Shaker talks about this lack of synchrony, this uncoupling between swallowing and breathing. This is when we see that loss of bolus control, gulping, gurgling sounds, multiple swallows, coughing or choking, all sort of relating to our fluid threats to the airway and our aspiration risks. So again, with that in mind is we're going to pace all babies by stress cues always, right? But then the second option that we have for pacing babies could be a little bit more restrictive to sucking or swallowing bursts. I really do believe that if we do a good job pacing these babies by stress cues on day one, we often don't need to make more restrictions as they become closer to discharge or problematic. They just don't become problematic often, because the earlier we pace, the better we are routing those neural pathways, the sooner we are teaching these kids. Just something I didn't mention before, I want to mention before we talk about sucking bursts, is what I often find is we're really teaching these kids when we pace. Oftentimes we'll start pacing at the beginning of the feeding, and sometimes they need pacing really frequently. But they oftentimes, towards that middle of the feeding, get it, and they do it all on their own. And I love that feeling when you're working with a parent and the parent looks at you like, oh my God, they're pacing, they're doing it on their own. I'm like, yeah, mom, dad, you did that. You taught them. And it's the most exciting feeling for these parents, because they can see that what they're doing is paying off for that baby. But of course, you burp the kid and then you go back to feeding and they need to be paced all over again because they forgot in that short period of time. So again, you pace the first couple of sucking bursts, and then oftentimes they pick it up all on their own, which is very exciting for everybody. Again, and it's a real testament to what we're doing is working. We are teaching them that rhythmicity and that coordination. But sometimes it doesn't work. Sometimes we're pacing by stress cues, we're doing elevated side lying position, slow flow nipples, we're doing everything we can, and these kids continue to have maybe cardiorespiratory events or fatigue with their feedings and unable to complete all feedings by mouth. So we do move into a little bit more of a restrictive pattern. And so when I get called in for a consult, again, I always try to pace by stress cues. I don't wait for that 2-minute mark. I know a lot of therapists who are trained to administer the NOMAS, they allow in the feeding evaluation 2 minutes of no intervention to get a very good picture for these babies. I tend not to do that. I feel like it's baby torture. Why am I going to sit there and watch a baby flail for 2 minutes before I help them? So usually at the first sign of stress, I'm going to intervene. But as I go through and I am intervening by stress, I can also kind of see if it's working or if it's not working. Is this child still having increased work of breathing or events or a lot of stress? Because if that's the case, sometimes I'll try to pace them before the stress hits. So I usually start off pacing closer to 8 or 10 sucks per burst. See how that's going. If, again, they're becoming problematic, I'll reduce down to anywhere between 5 and 8 sucks per burst. And then the most restrictive that I will ever go to is 3 to 5 sucks per burst. And what I will do, especially if I'm down to 3 to 5 sucks per burst and it's a little bit of an older child, maybe like a 36 or 37 weeker, I'll do it in 24-hour intervals. I'll say, okay, every feeder is going to be very restrictive. Pace every 3 to 5 sucks per burst, and then pull that nipple out of baby's mouth to let them breathe. And I do this for a full 24 hours, come back in and reevaluate. And it is very often after that good 24 hours of learning, I can bump them up to either 5 to 8 sucks per burst or 8 to 10 sucks per burst, or even better, just up to stress cues. This technique is also now being done more and more under objective instrumental assessments like fluoroscopy or FEES. And this is great. We're actually finding some babies don't need to be thickened, which is such a pain in the tush for us to thicken these babies, and something we really want to try to move away from. So sometimes we can prescribe a more prescriptive pacing order based off of what we're seeing under these objective tests. And in that case, it is definitely for a longer period of time, not just a 24-hour interval. We'll keep them on that for a month or so and then reassess as they get older. So we have some really nice outcomes with that. So moving away from when, we're going to start talking now about why. And I came up with 5 excellent reasons to pace. The first one is it reduces infant stress during a feeding. So what stress is? It's a physical, chemical, or emotional factor that causes bodily or mental tension. And recent research is showing that things like a diaper change and feedings are equally as stressful to some of our preterm babies as painful interventions like a heel step procedure, right? So these stressful procedures often prime their systems to subsequent handling, producing these heightened responses to routine care. All right, so it's really, really important that we try not to cause stress. We also know that stress causes brain alterations. This study that was done out of St. Louis in Washington, it was Jillian Smith and Bobby Pineda published this in 2001. They found that increased exposure to stressors in the NICU were associated with decreased brain size in the frontal and parietal regions, altered brain microstructure, altered functional connectivity between the lobes, and alterations in neurobehavior at term equivalent. So they really stress that these patterns can cause these abnormal or immature responses to their environment, all things that we certainly want to avoid. All right, here's an MRI images from that publication. So those A brains at the top were full-term babies. These B brains were babies that had only low levels of stress. So you can see the interlobe connectivity, and the stimulus wasn't like some kind of environmental stimuli, but the interlobe connectivity between the right and left hemispheres were reduced in those infants who had just low stress levels. And then those C brains on the bottom, these are brains that were exposed to high levels of stress. And you can see how reduced that functional connectivity between the lobes are. So, oftentimes we think about preventing brain damage and we go right to thinking about intraventricular hemorrhages causing cerebral palsy or oxygen use causing ROP and blindness. But sometimes it's really, our focus needs to be on these GABAergic cells, these small little microstructures that can lead to later cognitive deficits, emotional disturbances, sensory processing disorders, depression, suicide risks. All of these things are now being related to stress and prematurity due to these micro alterations to their brain structures. So we want to make sure that we're avoiding that as best as we can. Also thinking about neonatal reflexes, they're important for foundations, but when we're doing things that aren't typical, we often impede development and signal these abnormal developmental trajectories. So that's, again, one of those reasons why I wasn't crazy about breaking the seal and popping it into the corner of the mouth, because you don't know what that outcome is going to be. It's not a typical way for them to feel things. All right. So with that present knowledge of negative effects of stress, we want to make sure that we are doing everything in the most least stressful manner as we can. And this falls really nicely into our ideal neurodevelopmental care, which is to support the brain development by providing developmentally appropriate experiences. So again, pacing really nicely falls into the ideal neurodevelopmental care model. Moving on to another reason why we like to pace It improves respiratory status throughout the feeding. So again, thinking about this, keeping this kid at a nice steady jog rather than letting them sprint and poop out, right? We also know that we want these kids to maintain nice oxygen saturations through their feedings, and we want to finish them with a nice flexed body position at the end of their feedings. We don't want this. We don't want a baby who's completely flaccid and exhausted. Our goal as feeders isn't to get the liquid in and expend all the energy reserves that this baby has. We want to give them a positive experience. We want to end on a positive. So we want nice flex positioning at the end of the feeding. And this is really supported in the 2 research studies that are published regarding pacing. One was done by Laura Moristat and colleagues in 2003, who found that babies who were paced had reduced bradycardias. And the function for that was probably because it improves their oral control of the bolus, and it increased the efficiency of their sucking patterns at discharge. And this is probably because we're teaching them, right? We're literally teaching them how to eat and to coordinate. So the fact that they are more proficient makes good sense. The second study was published by Suzanne Thoyer in 2012 and found that these kids had less O2 variability, less O2 decline, and less time spent desaturated. They had less heart rate fluctuations. They had less behavioral disorganization and better fluid management. So again, it really does support the respirations for these children. The third reason why pacing is so great, it reduces the risk of liquid misdirection into the airway. Right? We do know that suck, swallow, and breathe in coordination is one of the greatest causes of aspiration in preterm infants. As explained before, that ability to open and close and open and close and open and close the airway is pretty tricky. So these kids find themselves in a lot of difficulty when they're disorganized. Compromised airway is associated with apneas, bradycardias, and DSATs. So when we are not pacing these kids, we're risking an increased risk of these events, which is going to significantly sometimes prolong their hospital stay. And we also know that reducing airway compromise improves medical outcomes and long-term respiratory health. So I have a fluoroscopy here. I'm just going to show you briefly. This is a nipple in the baby's mouth. And then it's not a great picture, but it does show my point. Here's the baby's shoulder. Here's the baby's spine. Here's the back of the baby's skull. So here we have liquid that's going over the base of the tongue, and it's here in the pharynx. So this pocket is the vallecula. This is a pocket of the piriform sinus. Oh no, I'm sorry. This is the piriform sinus. This is the vallecula. This is liquid in the back of the throat. But you can see that there's a black pocket here, this black nasal pharynx, and this black pocket here. And the trachea is also a little bit darker. This is a baby who's trying to breathe while liquid is in his pharynx. So again, this uncoupling of safety. We want to swallow and then breathe when there's no liquid in the pharynx. So this is a baby who's, again, breathing, because you can see that it's darkened here in the nasal cavity, the pharynx, and the trachea, while having all of this liquid in the back of their throat, their vallecula, and their piriform sinus. No good. So pacing can significantly improve that. Another reason why is it's most similar to the patterns of breastfeeding, which is our gold standard and always will be. We know that when you breastfeed a baby, we can feed for 30 to 45 minutes. And they can do it this long because they are better self-regulated on the breast, and they could take these nice long pauses without being rushed, right? I don't ever have to worry about a nipple being jiggled in this baby's mouth when they're breastfeeding, because moms tend to have a little bit more understanding of the timing for breastfeeding. But when we utilize the pacing technique during bottle feeding, we can say, this is the way the baby would be feeding at the breast. They feed, they dawdle, they take pauses, they feed again, they're sucking, they're dawdling, they're taking their time, all right? Another great reason is that when a baby is breastfeeding and they're taking their time and they're in control and they're regulated, the flow rate of which that liquid is going into their stomach is more appropriate. Babies aren't supposed to be getting 30 cc's in their stomach in 10 minutes. That is an inappropriate way for the liquid to enter their stomach. It's going to cause this greater distension of their gastric distension, and it's going to cause greater chance of gastric recoil, which is going to cause the reflux events. So when we pace, and we're really infant driven, I don't care if we go 30 to 45 minutes for the feeding, as long as we are really, really facilitating an infant driven pacing technique. But I do absolutely not expect anyone to feed a baby for 30 to 45 minutes if we're using encouragement, if the baby is fatigued, showing signs of disengagement. It's not about getting those last 5 cc's in these kids. It's about making sure the feedings are well regulated, safe, and stress-free. So again, all good things when we're pacing, a little bit more similar to breastfeeding. And then the fifth reason, again, I keep talking about it, but I cannot understate, we're routing neural pathways. These babies are here when they're not supposed to be. There is a tremendous amount of brain growth that happens those last 13 weeks of gestational age. This brain triples in size due to increase of neuronal maturation and wiring and myelination, all right? Whenever in any type of development, you see this rapid rate of development, it always leaves the brain more vulnerable for damage or risks of an infarct. And again, it's not just that blatant what we think of for, an IVH and cerebral palsy, but it's more of these GABAergic cells. And those are the ones that really map for cognitive development, emotional disturbances, depression, ADHD, autism. So a huge focus is there. When we are pacing, we are literally routing the neural pathways to teach this child how to regulate. So again, really, really important reasons to pace. And what we're seeing is within that immediate feeding, these babies are catching on. They need to maybe be paced a couple of sucking births, and then they can do it on their own. And similarly, you start pacing these kids from day one, and they're going to start doing it better on their own towards the end of their discharge. Again, consistency, important for the infant in terms of how the brain is being wired, but also for the parents. We want to encourage empowerment for these parents and competencies for these parents. So really, you should be using these unit-wide ideas. Just touching quickly on family-centered care, which again, pacing does support. It enhances the attachment between the infant and the family, which improves the long-term physical, emotional, psychological, and feeding outcomes of these infants. And it empowers the parents. You want them to feel proficient. You want to come in and praise them. Wow, mom, dad, great job pacing your baby. That was fantastic. Think about what that's going to do to them. That's going to make them so happy. Again, the more we support those families, the better outcomes we're going to have for our babies. And then the pacing technique is supported by all of these other approaches that we talk about in the field of neonatal therapies: dynamic systems theory, cue-based feeding, infant-driven, infant-guided, relationship-based, co-regulated, family-centered, and parent-infant attachment and interaction theories. So pacing is really supported by all of these. You want to make sure you always expand your ideas of success. We want to make sure that infant had the opportunity for a positive feeding experience, looks comfortable throughout the feeding without distress, has quiet swallowing, maintains good oxygen saturations, and finishes the feeding with good midline flexed body positioning. Notice how I didn't talk about volume. I don't care if that kid takes 5 cc's as long as he does it in a well-controlled, well-supported, very infant-driven way, all right? And some takeaway points for you all. We want to respect where each baby is neurodevelopmentally. We want to recognize and interpret their behavioral cues during the feedings. We want to respond to their behavioral cues by using appropriate feeding strategies, such as pacing. Now is the time to establish unit-wide collaboration, both for the babies and for the families. And everything that I talked to you about today, teach to your staff, teach to your parents. I make this pretty parent friendly. So please use my words and use my examples about sprinting versus jogging and being your baby's brain and teaching them how to stop on their own. This stuff is for you guys to go and make some positive improvements to those kids that you're working with and their family. So again, our overall goal is to ensure that every feeding experience is positive, pleasant, and nurturing, regardless of the size or age of the infant. Also, please keep in mind that I focus most of this on a preterm baby, but this is all going to be true for children with complex medical issues, full-term babies at any age. This pacing technique is never unwarranted, especially when it's used by stress cues. So with that, I am going to thank you all for listening in today. I am always available for questions. Feel free to email me if you have any questions or advice, and I look forward to hearing your questions and answers and getting back to you with those. Thank you again.